That moves us on to page 167, Audit and Risk Management Committee. Paul, you can assume you've read the report. It's relatively brief this time, but any key points you want to bring to the board's attention?
Not really. I mean, we met in August to consider the ICB accounts, and there was a particular issue which I won't go into detail about capital departmental expenditure limit and their technical adjustment for revenue that whole town hall. NHS England did subsequently approve an amendment to the ICB's CDL figure, and that enabled the accounts to be signed off. And just as a further update, I did get confirmation on Monday that BDO had issued their final audit report, including the work on the value point conclusion with no issues to report, and therefore they were able to issue their certificate of audit completion. So that essentially brings the accounts round to a conclusion for 2022-23. No other issues to note apart from that.
Great. Okay. Well, that's excellent news. So, certificate of audit completion. We've got a clean set of accounts. We've got the annual general meeting this afternoon, in which we can publish them to the public. So, I think that brings everything to a complete loop. So, I think that feels relatively straightforward. But any questions or comments? Adam?
I think this is important to make because of the delay in the issue. Both myself and everyone will are meeting tomorrow to consider what is the right approach with our external auditors to not be in the same position as this next year in terms of the timelines for that. So just in terms of closing that action, we just feel we need to be clear and have a proportionate response, recognising our external auditors are asked to do 4 sets of accounts, not the one they expect us to do, but how do we make sure we're not in this position again next year and get everything done on time is probably our key sort of main focus of that conversation tomorrow.
Okay, so we should just probably note that action then. I think in the minutes then, Kerry, please, sort of combination of Hannah as Chief Finance Officer, School Audit Committee Chair, and self Chief Executive, just to review the how we avoid this situation happening. But again, the good thing is next year we'll only have 1 set of accounts. So that's a step in the right direction. And we should also say thank you to Hannah and your team for all the work that you've done involved in all of these different accounts and the annual report too. So thank you for that. Okay, that brings us on to the next item, which then is obviously the Board Assurance Framework, page 170. So Hannah, I think, as the other lead senior responsible officer on this, and you can assume we've read the report, but any key points you want to bring to our attention?
Yeah, thank you, Chair. So following the approval of the final SDP at Board in July, then the corporate governance team have been working to make sure that the current iteration of the BAF absolutely and accurately reflects all the final actions that we identified as being priorities for the work streams. And we also agreed that assurance of progress against the SDP commitments would be presented to the board on a regular basis. And so that new process is that the SDP delivery reports will be presented to the board committee and then provide assurance to us and the board through the committee chair's report. And then, of course, where there's more assurance needed where it crosses committee, then the SRO chair of the committee will talk to the other committees around that. We've covered earlier that Chief Nursing Officer will join the FPC, the Finance Productivity Committee, and I think that's the admin side. So there's been one change in the current risk score, which was the improving use of digital technology and data. So the current risk score was actually reduced from 20 to 16 because of the impact of completed SDP actions. And then the other change was, as in the summary, was around the action to identify a clinical leader for each of the 3 integrated community team frontrunner programmes by the end of June. So there's now a different approach proposed to that, which is described in the paper. And then just to update further, it was agreed at the last EXCO meeting that Adam referenced that a review of the BAF would be undertaken as part of the internal governance and partnerships review that our Director of Governance Assurance is taking forward, which will be in Q3 into Q4. And so we'll actually be looking at different examples of ICB BAFs across the country that represent a good diversity. And so we'll be reviewing that and looking at similarities and whether there's any changes that we would want to make. Thank you, Chair.
All right, thank you very much. Jack, as our Director of Assurance and Governance, do you want to say anything about the review that you're going to conduct?
Absolutely. NHS England has asked all ICBs to look at their governance and partnerships over the rest of the year. It's something that ICBs can tailor to make it suitable to them. So we'll be talking at the exec committee, and I'll be talking to you about the exec scope of that. And the idea is that work will take place over time, talking to partners, and then come back to the board next year.
Yeah, thank you for that. So, colleagues, any specific questions or comments on this extensive board assurance framework document? I had one actually, if I can. I suppose it's just trying to understand the process, Hannah and Jack. You know, in terms of at what stage does a significant operational risk in the BAF need to be escalated and move into our board assurance framework? You know, and I'm just looking at the example, for example, of about migrants and refugees. We've got an operational risk of 20. You know, knowing from other sources that risk is not likely to decline anytime soon. And I'm just wondering what process we go through to potentially escalate that onto the board assurance framework rather than the operational risk register. And I just wasn't clear how we made that decision.
Yeah, no, I think it's a good question. So the risks are discussed as part of the IAG, the exec committee, and it's discussed that the mitigations that we've got in place to manage that risk. So it would come through the IAG into the exec committee if we felt that the mitigations that were in place weren't sufficient at that level, and we felt that the risk profile was increasing. Then we would need to talk about increasing that.
Yeah. So the governance route then is through the integrated assurance group, which is a subgroup of the executive committee, as I understand it. Is that correct, Jack?
Yes. Yeah. I was just going to add one point. As Hannah summarised earlier on, following the board's agreement that the BAF should be aligned to the SDP, the BAF risks that the board will regularly see are those SDP risks. So high scoring risks like the one you described will get shown to the board as part of this process. But at the moment, given the way that we form up the BAF, it wouldn't join the actual BAF because that's not one of our strategic priorities.
Not necessarily.
The board would see this.
Not necessarily as that, but if I could just pursue that example for a moment, and I'll come to Adam, is that actually that could have an impact on access to services. If it actually sort of reduces resource available for other services, it could have an impact on finance. So there might be something like that could be a cross-cutting theme that still has an impact on our SDP priorities, potentially.
In which case we could think about does it move into one of the BAF areas where the most significant one won't fix most likely?
Adam, sorry.
This is always the debate, isn't it? Important to know about when's a strategic risk and when's not. But I've noticed something about, I think, us recognising that in our current governance arrangements, we need to be clear that the exec committee oversees the operational risk of the organisation system. But I therefore think we need to agree and need to look at our risk management policy again to make sure it is explicit where is judgment exercise and where is the scoring exercise. So I think what works better in governance terms is a scoring exercise means we therefore highlight it to the board regardless, even if we feel there are solid mitigators in place to get that piece right. So I think if we agree that we will work with the audit and risk committee to therefore be clear what is the role of the exco in terms of escalation, what are the audits, we're all clear about that and come back to board with the position about how we do that. I think you highlighted, Stephen, quite appropriately an example where I think there is an emerging risk, but is it being surfaced in the right committee of the board and being held at the board level? I think possibly not, which therefore might indicate we might have a small gap in our control, so let us look at it and try to cut that off.
Yeah. And Paul, it feels sensible that actually the Audit and Risk Management Committee should keep an overview on this situation. So you be content to get involved in that action?
That's absolutely right. I think ARMC, the role is to look at risk management across committees, not individual risk or individual sort of BAF risks. And I would see part of that is how do we ensure that we have got the right risk in the right place and that they are escalated as appropriate. Because you're absolutely right. I mean, that key risk Operation 20 does have impacts on other areas of activity. We've talked about that in the context of F&B, for example, the funding risks associated with that and the knock-on impact on other areas.
Okay, so I don't want to focus just on that pure example, but I've just used it as a way to demonstrate how we appropriately escalate and just making sure that our governance process is working that way. Because that feels like the purpose of the board assurance framework to me. Okay, so I think it sounds like there'll be a specific action there that'll come via Audit and Risk Management Committee back to the board, so that gives us an appropriate route to provide assurance on that particular escalation process. Any other thoughts or comments or questions on this item? There's a lot of information in here, and I know from a finance and performance committee, we've taken on the responsibility as the lead committee for access to services, and I think we'll need to think about how we, I think, appropriately dig into a large number of risks and then make sure that we link it in, particularly with the patient experience committee. I think if we're identifying early on that we need some additional quality impact assessments done on any of the risks. So I think we're very alive to that, and I think the finance performance committee meeting on a bi-monthly basis, then I think that would provide multiple opportunities to provide any sort of requests of help from patient experience committee soon. So that's the intent. Okay. Good. Okay. On that basis, let's note that report with our thanks. I think that's really important. So appreciate that very much. So forward plan onto the next item. I sort of referenced this slightly earlier, actually, in terms of page 199. I've identified a number of changes from our last version in red to make it easier to sort of try and track the changes. And I was really conscious that in November, we seem to have a real surplus of really important topics. And I think through experience of Finance and Performance Committee, experience through the System Oversight Board, trying to do more than two deep dives in a particular meeting means that you're not doing justice to what are really important topics. So I think spreading out the workload felt important. So that's one of the reasons that we've actually moved health inequalities and primary care back a one policy. I think thinking of next year, I was also wanting to be quite systematic in the approach to ensure that all 11 of our SDP priorities get some board airtime, because that wasn't completely the way to be fixed. And to make sure that we've got less about updates, because I think updates are best done through committees, and the board gets the annual overview and report. So that was the intent to the changes that we've made. But can I just check that, that first of all makes sense, and are there any other suggestions the board would like to make to the forward plan? Yeah. So I think being really specific around it, then I think in terms of November, then obviously I think there's an important paper around the West Sussex stroke decision-making business case. There's an important paper around digital technology and information, which is something that again is another of our integrated care strategy priorities. And I think another topic that operationally gives us concerns is the whole area of mental health, learning disabilities and autism. So I think of three big topics, they felt they were the ones that were the most urgent and the most important for the board to discuss. So it was quite a conscious decision-making process. Not that other areas weren't important, but they were three that felt we needed to do. Everybody's content?
Yeah.
Okay, on that basis then, can we approve the board plan for implementation? Thank you very much. So that just leaves us then onto the next item around public questions. Now, obviously, because we're not live streaming the meeting, we'll be recording the meeting now, as we agreed at our July board session. We're only taking pre-submitted questions. But Tom, I understand there are a couple of pre-submitted questions. Do you want to just identify what those are, and then we'll see if we can discuss them?
Yeah, thank you, Chair. So we'll ask two questions. So the first is in relation to integrated community teams and health inequalities. So the question is there any work being undertaken to identify and quantify the health conditions that currently absorb the greatest amount of time and money in each place? And could these health conditions, once identified, be allocated scores for prevention and resource availability?
So I'm just wondering who's best, for an integrated community team, that might be Amy, but other colleagues might want to come in as well. But how are we going to take this forward through the integrated community team?
I think this is a really important question for any healthcare system in the country, and it's a really big question. I think it's fair to say that despite probably lots of years of progress in medical technologies, we still see the biggest causes of death and indeed expenditure being around diseases like heart conditions, so CVD, also diabetes, and I think it's fair to say we're seeing an uptick in dementia. As a Sussex healthcare system, it's probably fair to say that, and we are probably no different than any other system in the country, probably don't have a fair understanding of the cost of these different conditions and the treatment expenditure across the different provider centres. So we don't have a cumulative cost that we can link to this. And therefore that doesn't allow for the targeting of how then you place some of the, I guess, health inequalities monies that are referenced in the question. But I think that's definitely an aspiration and one of the reasons why we have developed the Sussex Integrated data set in order to start to get a longitudinal understanding of the patients in our system and also how different people cross multiple provider centres. So that piece of work alongside the work we're doing around population health outcomes and also the financial underpinning that is mentioned in our SDP linked to our strategy should all come together to start to give us a view of this. But I think in reality we are slightly far away from being that sophisticated as a healthcare system. Also another thing to say is that I think the pandemic has shown us that health inequalities aren't just a product of health, and that we can't just look at where we're spending money in healthcare. And a lot of the work that we undertook during the pandemic to improve access related to understanding how people live in their daily lives, and that's also an important consideration when making spending decisions around health.
Yeah, so I think the importance of getting consistent data set across the piece is really important. To share that intelligence across all partners across the system, across health and care. But then importantly, then making clear decisions around what we're going to do about it. So that's which is precisely why integrated community teams are so important to the delivery of our integrated care strategy. So thank you for that, Ian. Okay, Tom.
The second question is around the delivery boards of the shared delivery plan, the cross-cutting themes across them. So the question is the board convinced that the delivery board structure is adequate to guarantee delivery of the shared delivery plan, or should the board structure be amended by the introduction of a set of task and finish groups to look at common elements such as clinical leadership, data drivers and evidence, the complete clinical pathway, patient's life course, and patient-centred pathway?
Okay. Well, obviously, I think we can always sort of look for opportunities for improvement, but also we need to understand we've only just implemented this. But maybe Lisa, could you maybe sort of start us off on this, and we might come to Ivan.
Colleagues may want to come in. There's quite a broad question, but if I just take 3 key points in that. So, if you look at the terms of reference across those delivery boards, the System Oversight Board reviewed those in detail and endorsed them, and that included the clinical representation that's required on those, the user voice, and the approaches in terms of consistency across those boards. If you think then about the question around the structures and the common elements, both our delivery directors come together on a weekly basis to make sure we're looking at cross-cutting things and dependencies, but the System Oversight Board, as part of its duty, obviously, we talked about that today, looks at an overarching outcome framework, looks at the overarching approach to clinical leadership and those other elements. So ensures that approaches and the entire shared delivery plan. But I think probably then the third just quick point I would make is that, to your point, Stephen, quite rightly, the System Oversight Board will annually review the effectiveness of its governance, and we take that in our forward plan for February.
I suppose the only context, I suppose, just from my point of view, is that we are talking of a shared delivery plan across the health organisations of which NHS has accountability, and care organisations and the voluntary sector as well. So there is something around who's got the legal accountability and where the sovereign relationships and responsibilities start and end. So we need to be aware that we put a shared delivery plan together of partners that are legally distinct. So I think we need to understand that. That's what we're trying to navigate through. But Alan, as the Chief Executive of the system, what's your view on that?
So it's a great question because you can cut this so many ways. Yeah. You can't cut it all ways. Let's be really clear. So we agreed a way of doing it across our whole partnership that we felt that was the best way to get it right. The model that has been proposed for the question would therefore be a different way of doing it. I think the way we approach this is though, this is a systematic change that I cannot prosecute by telling someone to do something. Really important. That's not how a system operates. And frankly, it's not really how most things work to get the best out of people anyway, even if you could pull that lever. Let's be frank. So therefore, what I have the privilege to do is work with a bunch of committed leaders who want to make the right change in the operation. At times, it's tricky. The reason why I think this model works for us at this moment is it kind of calls out the right. So therefore, so for example, Jo today may have an issue in her trust about mental health services. She will speak directly to Jane about what the issues are, about how that happens. And I think that is the right evolution for us at this current point. Setting up a set of task community groups below, I think would be more meetings that I'm not sure really get to the crux of it. We have had a history of having an over-bureaucratised system, and therefore we end up not actually being really accountable. So I think my sense would be, the question makes me consider how would we do it differently. But I think we've agreed that at the end of this year we'll do a governance review that I think should be looking at not just governance, but also culture. It was actually culture that override that with 5 statement content. So are we a system where we can raise concern, debate it, challenge it, and have a solution? That is the key part. And then if that's the right governance model, that kind of works. And people may make that's the wrong approach, but looking across all international models of healthcare and all international models of what works, it is those kind of levers that have been proven to work. If we're going to go back to the first question, which was moving resources from one part of the system to another, if we're going to move resources from acute services into integrated neighbourhood teams, we need to feel confident that the leadership community all buy into that model. And I don't think the model proposed for the question is going to achieve that aim. So but happy to be challenged on that when we get our external governance review to therefore check that going forward.
I also think from a pragmatic point of view, I think we've spent months and months putting together a shared delivery plan, a lot of really good engagement. We talked about that at our July meeting. So I think we have to give that chance to operate. That just seems reasonable. But I think an annual review of these arrangements is also appropriate as things change. You've seen ever since we work. But I don't think we should be changing every 5 minutes. So I think an annual review feels right to me, just as a principle. And I'd ask the board to continue to support this board going forward. Okay, thank you. So 2 questions there. If there were there any other questions, Tom, which we answered today? But if there were, how are they going to be responded to?
Yeah, so we'll respond then to the individuals who asked the question directly outside the meeting.
Perfect. Okay, so therefore we will actually sort of fulfil our duty to engage and to respond. Okay, thank you, colleagues. That sort of brings us towards the end of the meeting now. I think just in terms of some closing remarks, when and where's the next board meeting going to be held? Well, that's going to be at the University of Sussex on Wednesday, the 29th of November. So again, in the morning, so it'll be a normal 10 o'clock start with as we said in the forward plan, a really interesting looking agenda. Before we do close, I'd just like to thank everybody for their contribution today, and also thanks to the teams who've been involved in writing the papers, preparing for the meeting. As always, it's a team effort, and I really, really appreciate the support that we get. And finally, I'd just like to remind everyone that the ambition of NHS Sussex is to work in collaboration, is to work in partnership, not just with our NHS organisations, but with local authorities, education partners and community partners too. And the purpose of that is to deliver our integrated care strategy, which we've called Improving Lives Together. And that really goes back to why the integrated care boards were set up, about improving health outcomes, reducing health inequalities, enhancing value for money and supporting social and economic growth for all 1.7 million people living in Sussex. And to achieve that, we're working through our shared delivery plan. Those 14 priorities we've identified, and they're listed at the top of our agenda to keep us very much focused that that's the job in hand. So with that in mind, I'd just like to close today's meeting and wish you all a good day. Thank you.